SENDoc project is a European project. It's a Northern Periphery and Arctic Interreg project. We started the project in 2017 and it completes the end of this year, 2020. So it's a 3-year project and it involves 4 main partners. A physio partner in Finland, clinical partner in Sweden and a technical engineering partner in Cork, as well as ourselves in Ulster. The core aim of the project is to test mobility, strength, balance and also well-being and exercise through sensors. Can we use sensors to measure all of these things to support independent living? So the SENDoc project, which stands for Smart Sensor Devices for Rehabilitation and Connected Health, has introduced the use of wearable sensors into these 4 main regions. And we are assessing sensors' technical, clinical and social acceptability in these regions and how they can impact patients, particularly elderly or isolated rural patients, in terms of health and care delivery.
When the project was initially written up and developed, it was thought that there would be one sensor system developed for one particular condition and distributed to all the partners. When we started the project quickly evolved into working on multiple demos, multiple conditions, multiple technologies.
In Cork, for example, we tested a wearable glove, which is a glove that you can put on the hand. And we tested it with Parkinson's patients in a Parkinson's clinic setting in St Finbarr's Hospital in Cork. Locally, in our own trust, we have tested the glove in a rheumatoid arthritis clinic. The aim of these tests is to see if this wearable glove, as an example, could be used to remote monitor well-being. This has become particularly important in this season of COVID lockdown. We need clinical assessments and clinical management to continue on the same level as it would have done pre-COVID. And these types of wearable sensors, not ambient sensors, but wearable sensors that you can put in your bag and take home, that you can put on yourself and monitor your own condition, are ideal to remote monitor in lockdown scenarios. Conditions don't disappear in lockdown scenarios. If anything, they need to be managed more carefully. In Finland, we tested a lot of gait type technologies. So we used insoles in shoes to test gait for post-stroke patients.
We have tested so far 17 different sensor systems that are connected to elderly persons' independent living. And we have a certain protocol where we test the accuracy together with golden standard equipment that we have. And the next step, if the system is shown to be accurate enough, we have tested them in real working life rehabilitation processes, both in clinics, in home rehabilitation teams, with our associate partner Siun Sote, which takes care of this region, social and healthcare public services. As well as examining the accuracy of those sensor systems, we analyzed the usability from the end user point of view, both older persons and therapists. We focused how comfortable the sensor systems are to wear, are they easy to do on, easy to do off, how easy it is to connect the application from the tablet or phone to the sensor systems, how time-consuming the process is compared to time of the single therapy or rehabilitation session, and also is the information from the report or the application directly or immediately beneficial to the rehabilitation process.
I found the experience of wearing it was very good. It wasn't cumbersome in any way, that you could do your daily activities as normal.
Well, it was very easy to use. Absolutely so easy, anyone could use it. And I can use it, absolutely anyone can.
When you had it on, you weren't conscious of the fact. The material was very good, soft, rubbery, and it just blended in.
It was nice in your arm, it was easy to read.
Once I got used to the app, it was very straightforward. So it was easy to sort out and easy to use on a day-to-day basis.
In Sweden, on the other hand, we used accelerometers to test if elderly patients living rurally were more likely to have falls.
Our unit at Västerbotten in Sweden is a test bed. We are doing a lot of testing, trying to develop better technology for care closer to the seniors in their homes. We have been looking at the frailty aspects and mostly on the risk of falling and risk factors for falling and how to measure them with connected health. We've collected over 1,000 seniors during the project, and we also did a little pre-registration, so totally we've had in over 5,000 seniors in our test centers and trying to develop better protocols for risk factor identifications for seniors.
So in Ulster, we've used our machine learning and artificial intelligence knowledge to develop state-of-the-art falls prediction models as well.
We at the Intelligent Systems Research Centre are a collection of computer and data scientists with background in smart data analytics and artificial intelligence. In the project, we've been exploring how we can use machine learning techniques on data that is collected by various wearable sensors so that we can extract the relevant information from this data and give real clinical meaning to it. This, in turn, allows clinicians to effectively use these devices to make informed decisions. One of the deliverables in SENDoc was the creation and development of a prospective falls algorithm for older people. Falls occurring as people age is a big problem for health service providers worldwide. In fact, they've cost the NHS £2.3 billion in the last year. Fall risk assessment, therefore, is a key way to identify those older adults who are at highest risk, allowing us to specifically target those who may need therapy or home modifications made, etc., in order to reduce the likelihood of them having a fall. The data for the study came from our colleague Anna in Region Västerbotten, and the study had involved an elderly patient wearing a small wearable device for 1 week, which was continuously recording their movements. Because our model was grounded on this free living assessment, it meant there was no performative tests, no training, or no monitoring by experts, allowing for a low cost and scalable way to collect patient data, as well as providing a more accurate insight into a patient's real gait behaviours. We developed a machine learning algorithm and applied it to the data that we'd collected. The results from the model we've produced are comparable to a state-of-the-art gait analysis system, which flags high-risk fallers, but at a fraction of the cost.
We also tested a back spinal sensor from Dorsify called the ViMove sensor.
Mostly, Ulster University aims to review in these initial tutorials what is the usability of the sensors. And the interesting bit about them is that we have these sensors before. You can say that you couldn't review the progression of a disease, while now with sensors is possible to review how is the progression of the disease in patients. We have noticed that the sensors are not in the standard that we thought that they will be, but also we noticed that maybe also many things have to change in the hospital and in the healthcare service delivery model, because you need to have, for example, training to patients and to staff members. They need to know how to use these sensors, how to interpret these sensors, and they need to know where to put them so they can have repeatable measurements.
One of the project outputs of SENDoc was to produce a transnational home-based service delivery model for rehabilitation. The model maps how prevention and monitoring sensor technology can be incorporated into the rehabilitation model and used going forward as a tool in the rehabilitation process. The creation of this model was an interdisciplinary effort and was grounded on lessons learned from all the teams over the duration of the SENDoc project.
By adding sensor technology, we have converted the traditional clinic-based model for rehabilitation delivery to a hybrid telehealth model, which is vital so we can connect people in rural and sparse communities to the specialists they need. The people most likely to need therapy are elders, and commuting to a clinic for them can be an arduous task. But by healthcare systems following our model, patients can connect to therapists from the comfort of their own home while still receiving the same level of care they would at the clinic. The correct use of remote monitoring sensors and technology, therefore, can vastly reduce the required number of visits to the clinic and and allow patients to be connected to and checked on regularly by the relevant experts regardless of their location.
When developing this kind of activities and equipment, there has to be very close cooperation with computer engineers, computer scientists, and us rehabilitation staff as an end user. We have to be able to discuss about what is possible and what is necessary.
As engineers and as scientists, you sometimes can be in a little box and not think too much about the users and actually what you're making can actually be being actually used for. And of course, as an engineer, the chance to test so many technologies with real users, and in particular get some of our novel technologies out of the lab in a real life setting, like with real users, and finding out the good and the bad from our technologies.
It's fantastic to be able to join in on the project because it's interdisciplinary. We are meeting colleagues from 3 other countries in other specialities. Me, myself, is a clinician. We work really close to the patients and the seniors. But having physiotherapists, having system developers, technicians, it's been fantastic. I think it's in the crossroads between the disciplinaries that the magic happens.
Key part of this project was a Scottish advisor called David Heaney, who was a research consultant, and he was an independent contractor who was based in the Highlands of Scotland. David had previously worked in the Making It Work project and also in another project with me, the Cine project. And in SENDoc, David was a key advisor in terms of knowing how NPA projects worked and supporting innovative delivery of health services in remote and rural northern areas alongside new technology. And unfortunately we lost David towards the end of this project, and I would just like to dedicate this project to David.